Good afternoon, and thank you for joining us today in this Mayo Clinic webinar on heart cardiac transplantation. I am Dr. Alfredo Clavel, and I am the Medical Director of our heart transplant program. I am joined today by my esteemed colleague, Dr. Philip J. Spencer, who is a cardiothoracic surgeon specializing in heart-lung transplantation and mechanical circulatory support. We have no relevant financial relationship to disclose within industry for this webinar. And we are going to mainly be talking today about current indications and changing demographics of cardiac transplant candidates. We want to understand the principles of hemodynamic optimization prior to cardiac transplantation. And lastly, the surgical team will discuss our strategies to expand the donor pool and preserve organs en route to transplantation. I start reminding us of the ACC-AHA stages of heart failure, emphasizing that today we will be talking about stage D refractory heart failure patients who have persistent severe heart failure symptoms despite guideline-directed medical therapy and have been properly treated by a heart failure team. This population has a significant mortality and morbidity, whether you look at clinical trials of heart failure registries. Getting back into the 2000s, it's been well documented that they have a very high mortality and, more importantly, high morbidity with a large burden of heart failure hospitalizations, particularly in the aging population. I have people often ask me as a cardiologist or end-stage heart failure cardiologist how to identify these patients, and we have now come to use, I did not invent this is a mnemonic that we use. It's called I Need Help. It's basically a quick way of looking at patients if they're needing any sort of intravenous inotropic support, if they are having end organ dysfunction such as renal or hepatic dysfunction. They obviously, in this particular population, have low ejection fraction or cardiac enlargement, have had unstable arrhythmias with defibrillator shocks, frequent heart failure hospitalizations, difficult to control volume despite escalation of diuretics, the development of hypotension and tachycardia that's difficult to manage, leading to discontinuation of guideline-directed medical therapy because it can no longer be tolerated. You have a patient that's headed that's already in the midst of end-stage decompensation. And so your options are basically going to be, the gold standard would be to consider cardiac transplantation, but that may not be appropriate to everyone. Fortunately, we have had an expanding palette of short-term and long-term mechanical circulatory devices that can, in some patients, be used as destination therapy. And of course, there's still options of using palliation and inotropic support to help mitigate symptoms on patients who are not candidates for either of these strategies. An important determination is that these are the current guidelines for the management of heart failure patients, clearly stating that short-term and long-term mechanical circulatory support have pretty strong indications and level of evidence, as does cardiac transplantation. So these are well-accepted therapies for end-stage heart failure patients. Just a brief timeline of where we're at with cardiac transplantation. First transplant was performed in 1967. And you can see that it took some time to figure out immunological parameters, organ preservation, refined surgical technique to achieve that 50% survival. And of course, nowadays, we take for granted the fact that the expected survival of heart transplant patients is well over 90% at 1 year. We look at the burden of disease, and we can see that there's a large number of cases of heart failure diagnosed each year, with a significant percentage of those patients classifying as end-stage patients, but a limited organ supply. Fortunately, there has been some better utilization of organs as time has gone on, particularly in the last few years with the use of hepatitis C positive donors, only able to do so because of treatment of being able to eradicate hepatitis C, and the use of donor after cardiac death donation for those donors who are not classified as brain dead, but that are still able to, we are still able to procure organs with our newest technology. I think that we have seen an improvement in the number of patients who can benefit from this therapy, and you'll see that today as we go through the presentation. The first point to make is that the fact that as we go along and look at the patients on the adult heart transplant waiting list, we can see that there has been stabilization and perhaps slight decline in the number of patients. That obviously, this is the law of availability and demand of organs to transplant reduces that. It is not because there has been a decline in the number of patients who develop end-stage heart failure, but there has been a change in the landscape of patients that we see. The predominant number of patients we see are cardiomyopathies, and specifically are now earlier recognition of genetic cardiomyopathies who have a much more aggressive course of disease that we can certainly anticipate that they'll need transplantation. While there has been a decline in traditional ischemic heart disease because of better treatment, there's also been an increase in the number of congenital heart disease patients that survive to adulthood, as well as valvular heart disease patients who've been treated surgically and have developed significant cardiac dysfunction. And lastly, patients who have been transplanted in their younger years who may need retransplantation 20 to 30 years down the road. So a slightly different breakdown of patients leading to transplant. There has also been a tendency toward older patients. People are living longer, and cardiac patients are no different. And so we're seeing that more patients are being transplanted later in life with excellent results. I think you've already kind of alluded to the fact that the refractory cardiogenic shock is the mainstay of treatment of using cardiac transplantation. But I want to point out to you that, although we won't be talking a lot about this today, that patients with severe ischemic heart disease that is non-revascularizable, who are very symptomatic, are also candidates for transplantation, as well as patients with primary refractory ventricular arrhythmias that are beyond the scope of therapy of electrophysiologists. We also consider those patients for cardiac transplantation. One common use test that you should be aware of in terms of evaluating patients with heart failure and trying to determine whether patients can fool you, and I've seen patients with very low cardiac index, poor cardiac function, who are still ambulatory. But if you look at cardiopulmonary exercise testing, there's a clear defined prognosis and survival of patients, particularly patients on appropriate therapy who have a peak VO2 of less than 12 mLs per kilo per minute, or in short, less than 50% of what would be predicted, particularly in the younger population. So we use this as a way of stratify and identify patients that are at risk. We also talk about potential contraindications for transplant, and in general, the things that we deal most frequently include immunological sensitization, excess weight, pulmonary vascular resistance, increased pulmonary pressures as a result of the end-stage cardiac disease, which I'm going to expand on in a minute. And of course, we are seeing now a plethora of psychosocial support problems and abstinence substance abuse that we have to deal with before patients can be successful. When it comes to pulmonary hypertension, it has been well defined that patients with an elevated PVR, more than 5 Wood units, or a transpulmonary gradient of more than 16, or a PA systolic pressure over 60, have a very high risk of RV failure and cardiac failure and death following transplant. Fortunately, we have a number of medical regimens as well as mechanical circulatory support combined with medical regimens to achieve better hemodynamics en route to transplantation. I put to you here the hemodynamic goals, and that's to have PA systolic pressures consistently below 50, a transpulmonary gradient less than 15 is ideal, and a PVR on less than 3. As our goal of treatment. And a lot of times, I think we'll expand a little bit of why we are using more mechanical circulatory support. As patients live longer with heart disease, they are more likely to develop problematic pulmonary hypertension that we have to deal with on the back end. Lastly, I'm going to talk a little bit about the current allocation system so that everybody's aware. This is our all allocation 3-tier system. 1A, 1B, and 2 was the level of priority. We are now on a 6-tier system. Status 1 patients are hospitalized on biventricular support. That's mostly going to be ECMO, Barian configurations of ECMO support. Status 2 patients are mostly left ventricular acute circulatory support. Impella intra-aortic balloon pump. Status 3 patients are going to be hospitalized on inotropic support and continuous hemodynamic monitoring, as well as patients with durable mechanical circulatory support that are experiencing complications. And your status 4 patient is going to be a variety of patients, but mostly mechanical circulatory support, outpatient inotropes, and patients who are at high risk of decompensation if we wait too long. And then what used to be status 2, status 5 is multi-organ patients who are listed heart, kidney, heart, liver, heart, lung. And status 6 patients is your ambulatory stage D patient who's relatively stable. Important consideration for special populations, as I mentioned, these are kind of the status 4 bread and butter congenital heart disease patients fall into that category. Of course, amyloidosis patients who may have preserved cardiac function also fall under that category. The retransplant patients, and increasingly, as we got them better at doing early genetic testing, malignant genetic variants that are associated with very poor prognosis, such as Lamin C and Titan mutations, commonly land in this special population. You can see here what happened to the waiting time on the newer classification, and for the patients who are acutely ill, this is really good news. For most of the time, they can get organs within 2 months. And even for patients who are relatively ill on the outpatient setting, they can still get organs inside a year when we are doing better medical therapy and better stratification of patients. With that, I'm going to turn it over to our surgical colleague to talk about our current landscape of mechanical circulatory support pre-transplant. PJ?
Thanks so much, Alfredo. I really appreciate it. So this slide is a really nice timeline of what heart transplant and bridging to heart transplant looked like in the 2010s. And you can see the green line in that histogram is largely the durable mechanical support bridge. And this came about after the development of at the time, Thortec HeartMate 2, which was a very powerful device to take people who are in shock and quite ill and weak and bridge them at home as a way to become transplant candidates, somebody who could tolerate an operation and get through transplantation. And then you see the smaller numbers on the top, the yellow and the white and the clear, are the smaller numbers of temporary RVADs that we would have used at the time, and a very small number of veno-arterial ECMO that we used at the time for very sick patients, as that was a rare thing before the allocation change that Dr. Clavell just discussed. And over that period of time, of course, the devices change, and the HeartMate 2 led way to the HeartWare HVAD, which was a smaller device and quite effective. And then eventually, the Abbott bought Thortec, and it became the HeartMate 3 device, an even more powerful and safer device. That's the only FDA-approved durable LVAD that we use today. And we still use it. It's a great way to take patients who are very ill with predominantly left ventricular failure and bridge them to transplant at home. Here's some of them, and as we go through this, the larger plethora and more advanced plethora that we're able to use today. Up in the left-hand corner of your screen, you'll see the Impella CP device, which is a small percutaneously placed device that works as a temporary LVAD that you can use in hospital, and that led way to, in 2020, to a really great and powerful device for heart failure, the Impella 5.5, which is a slightly bigger device placed through a graft sewn to the axillary artery that can give you almost the power of a durable LVAD in hospital to get the patient supported, improve their hemodynamics and physical status in hospital as a status 2 donor to bridge to transplant. And then you can see on the right side of the screen, the second photo, that's a CardioHelp device, ECMO, and with the new status changes, ECMO became a status 1, and we can even bridge our patients in hospital on full ECMO support, biventricular failure, effectively to transplant. And then at the bottom, you see 2 devices on the left-hand side. That is the HeartMate 3, which is specifically the device used today as our durable LVAD support. It's a great device. Our stroke risk is extremely low. Our GI bleeding risk is extremely low. However, it does still have an exteriorized driveline, and we still suffer from a smaller but real number of driveline infections over time. And then, unfortunately, currently still our only durable biventricular support device is the SynCardia Total Artificial Heart. Very rarely used today, but that is the only FDA-approved biventricular support device for transplants to be bridged at home. So indications for temporary mechanical circulatory support, largely these are patients with acute, very severe heart failure, in my hands, the ones I'm taking care of. And we're trying to bridge these patients either to recovery in the setting of maybe a large MI, now with a severe stunned myocardium, or for those who have had either cardiomyopathy leading to severe left or biventricular failure, or coronary artery disease leading to the same as a bridge to transplant or durable LVAD. The smaller devices are great options, such as the Impella CP, for to get through high-risk interventions in patients with ill hearts. So if you have a high-risk coronary intervention or VT ablation, the temporary use of an Impella device or similar is a great opportunity for that. Post-cardiotomy RV failure, you can use cannulas and either CentraMag or CardioHelp in an ECMO type support system to bridge them to recovery. And so examples of this would be something like an Impella 5.5 to transplant or recovery, or in your most severe shock patients, ECMO, either using CentraMag, CardioHelp, or even more devices with or without oxygenators and cannulas are great opportunities for your really ill patients in severe shock. And the purpose of all of this is either to bridge the heart to recovery, yes, but similarly as important is if you've decided the heart is not going to survive and you're going to need durable support or a heart transplant, to provide support for all the other organs so we don't descend into renal failure, liver failure, or certainly worst case scenario, issues with cerebral hypoperfusion. So here at Mayo, we experienced large growth in our volume in the post-pandemic era for a number of reasons. One is a change in allocation, allowing more use of organs from around the country, which brings organs to the sickest patients wherever they may be, as well as taking a more aggressive stance in terms of listing those patients so that we are made aware of patients who might be older with great hearts, further away, the advent of hepatitis C donors and the ability to use those with medical therapy and medical prophylaxis, and the advent of the donation after circulatory death in the United States, which first was used here in this country in the end of 2019. And this led to the ability to bring really suitable organs to patients with heart failure here at our institution, as well as others. So the key factors in our growth, as mentioned, is broad listing, which we'll go in great detail through. These hepatitis C donors, which became available to us really around the 2019 timeframe, since the advent of a cure for hepatitis C was discovered in 2015. The donation after circulatory death heart transplantation is possible because of either ex vivo heart perfusion, such as the OCS TransMedics device, or normothermic regional perfusion, which is essentially placing the donor after death on cardiopulmonary bypass to resuscitate the heart and other organs. And then on the recipient side, aggressive use of acute circulatory support, as discussed, aggressive recipient listing, and keeping an open mind to multi-organ transplant for those patients with multi-organ failure who really are appropriate to have this opportunity to transplant to survival. And last but not least, 24/7, year-round clinical coverage, a surgeon and a cardiologist open to hearing about these patients and available to offer the patient an operation. So this slide here, myself and Dr. Villavicencio, my colleague and boss, think is the key factor in growth of your transplant program and doing due diligence for your patients, and that is making the organs available so that you hear about them. So listing broadly with younger donors and older donors, even up to 60 years, a broad width in terms of both height and weight, doing away with specific gender requirements and looking at each donor heart in isolation, to use these donors from hepatitis C donors, which have demonstrated to be excellent, and using the technology available to us now to go out to 2,500 nautical miles, in other words, coast to coast, so that appropriate hearts can come to appropriate recipients. So to take a specific look at hepatitis C, again, a cure for hepatitis C was discovered miraculously in 2015. And then when I was a trainee at Mass General and Dr. Villavicencio was on staff, he and his colleagues first looked at using this cure in our recipients as a prophylactic form and then giving them hearts from hepatitis C donors. And this worked wonderfully well. This was able to control any chronic, as a matter of fact, we had no chronic hepatitis C infection in these patients, and this has really become a national protocol. And just a few years later, a similar result was shown in the use of lung donation and now even in liver donation. So a really remarkable advent, of course, for the treatment of hepatitis C, but also in the ability of using wonderful organs from donors and getting them to patients safely. In the advent of DCD, as mentioned, so that's donation after circulatory death, where these patients are not brain dead but have devastating neurologic injury and want to donate, we can resuscitate hearts that have stopped in a planned fashion using either NRP, which we demonstrated here in the use of a heart-lung block, as there's no available ex vivo perfusion for heart-lung block organs. But for heart organs, lung organs, again and again, this is shown as a wonderful technique to resuscitate the organs to good function and providing them to our recipients. So again, that's essentially placing the donor on bypass after the loss of heart rhythm and then resuscitation. And then, of course, there's the machine perfusion that we'll talk about in just a moment. So key factors in growth, again, is using ex vivo heart perfusion and now the advent of uniform cold storage in the form of the Paragon Sherpa Pack or the Trayferox cooler from Toronto, going the distance to get these organs, being open to complex redo transplant in folks who are otherwise good candidates and will benefit from transplant, just having more complicated operations. Extending your evaluation of these organs to look at hearts that may have mild hypertrophy that's clinically insignificant on echocardiography, and of course the use of the DCD organ. So this is the machine perfusion that's currently FDA approved and available. This is the Transmedic heart device. So you obtain these organs, either a DBD organ that's a significant distance away from your institution, or an organ that is DCD. If the heart is in standstill, you procure it in a rapid fashion and resuscitate it using the donor's blood on this device so it can be fully assessed, ensure good recovery so that it will be effective when you implant it in your patient. And then as we go into DCD, as this is still in its, not infancy, but early life in the United States, some key factors are important as you consider using this in your program. And one is the intensive care team at the site of donation. There needs to be an effective plan for withdrawal of life support. And as the donor hospital, you will not participate in the recipient hospital, you won't participate in this, but you need to be sure that you're comfortable with the way this is being done. Is it being done in an ICU setting, in the operating room setting, and that the aspects of that withdrawal of life support are discussed and agreed upon with the heart, lung, liver, possible pancreas, kidney teams, as well as the hospital that this is done in a compassionate and safe way for the donor, and the donor family in terms of a palliative care support for those families, for those donors, again, so that the appropriate withdrawal of life support for this patient, soon to become donor, are agreed upon and accepted by all participants in this process. Apologize. Okay. And then going into acute mechanical support, you can see the growth of the Impella program here at Mayo Clinic. The large blue devices on your histogram, those are the CP devices that are done here over the last 4 years, and you can see the growth there. Those might be done for high-risk catheter-based procedures, and sometimes to support a patient who has had brief myocardial stunning after events. And then the green device is that Impella 5.5 that we've really used for the treatment of cardiogenic shock with excellent results, as it can really give you essentially full left ventricular support. You can have a left ventricle in standstill, and this can support almost every patient outside of extremely large patients. If you look down at the bottom in 2023, The Impella folks at Abiomed came out with a right ventricular support device called the RP Flex. That's still in its infancy, and we've used that a couple times for biventricular support or sole right ventricular support. And here you can kind of see it drawn out through 2019, 2020, 2021, 2022. You see the growth of ECMO. You see the growth of bridge to transplant using ECMO, and the indications of post-ECMO support in those patients who are sick. We're able to get patients through even primary graft dysfunction using acute mechanical support. So it has really been a great opportunity to take sick patients who previously to my career often were not given an opportunity and were either going to die or may have had very long courses of suboptimal mechanical support. And so what does that look like? So if you look at previous to 2020 at our institution, what it looked like for offer acceptance prior to these mechanical support devices and aggressive lifts thing, we were way down here. And then here in 2024, we were way up here approaching the opposite end of that normal curve. And so that has served us well. I think it's demonstrating that our outcomes have not gotten worse, but instead gotten better using these donors, hepatitis C, DCD, long-distance donors. And it's allowed us to take patients who are very sick. Over 50% of our recipients, as Dr. Clavell had just let me know, are in hospital acutely ill patients with heart failure to transplant with good outcomes without really suffering these thoughts of post transplant outcomes from these hearts. Again, they are very good hearts and certainly deserve an evaluation. So we're going to get into the case presentation part of our presentation now. As we get to the Q&A, I just want to put a shout out that would like you to use the Q&A for your questions and not the chat function, because the Q&A is what we can see. So let me hand it over to Dr. Clavell again. We'll start going through a couple cases.
Yes, absolutely. Thank you, PJ. I think that hopefully you've gotten a sense of, first of all, you never want to have you or a relative have end-stage heart failure, but if you do, rest assured that there's an ongoing evolution of management of patients with better outcomes. And I think you beautifully stated where we've gone with mechanical support. Also comment, P, I mean, I think that the impact of the pandemic on this area was amazing. And we can say one of the good things that came of the pandemic, I'm sure that there aren't many, was the fact that we got very good at putting people on mechanical support percutaneously. And that's a huge deal, because taking people to the OR, trying to coordinate that time and putting people on mechanical support that way was not practical. You want to touch a little bit about how good you gotten at this?
Yeah, I will say that. I'll say certainly that is one aspect. And to take it the next step, it really took away some of the misconceptions we had about who is a candidate. Prior to the pandemic, I was in training, and we had very hard qualifiers of BMI greater than 35 to 40, age cutoffs for acute mechanical support. And over the course of the pandemic, we realized that these were not true, and we started putting people who were otherwise healthy, who came down with this new virus, on mechanical support, realizing they could do well. And so we started to really expand our criteria to older patients who otherwise would and should be healthy, and to larger patients. We realized that we could support them when we thought these larger BSAs, body surface area, would not tolerate these support devices. Oh, indeed they did. And so that's true. I think we've been able to, one, get better as a community at doing it, and two, expanding to patients we otherwise thought we couldn't support. Oh, indeed we could support them.
We do have a question. So before we move into the cases, as they come along, we'll just make this is the best part of this webinar. It's going to be our conversation. I really enjoy working with PJ. And the question comes about HIV positive recipients. Do you perform heart transplant in HIV positive patients? The short answer is yes. We have a protocol in place, vetted by our infectious disease colleagues. We are very much a multidisciplinary team. And we have, if these patients have no viremia and they're otherwise good candidates for cardiac transplantation, we would consider HIV positive patients for transplant. Have we done one? The answer is no. But we actually haven't seen a lot of patients come too. But we have a protocol in place, and I suspect that most programs will be very comfortable with that, provided that they're being cared for by the appropriate infectious disease team. And we actually have a couple of HIV experts on our transplant team. We're fortunate to know.
Yeah, looking forward to the opportunity to do the first one. I know
Absolutely.
they're itching to do it.
While we're at it, we can say that we have a protocol for the hepatitis B patients, particularly the hepatitis B donors, that we're looking at as a possibility that you're going to see more information forthcoming on that as the years go by, because, of course, if you're positive for hepatitis B, you may not be able to use that donor, but that may change in the near future, much like it did with hepatitis C. That's a great question. Thank you. I'm going to present the next case, and we'll have a few cases here. We'll see how many we get through. We'll like to keep these open, so please, questions come through as we go through the presentation. Well, feel free to put them in the live Q&A. This is a historical case, and I think I put this in here. We put this in here just to kind of give you an idea of where we were and where we are now. So this is a 26-year-old patient with a history of WPW and a multitude of ablations as a younger GRABA1, PARA1 patient who developed heart failure 2 years after her child. And he was labeled as a peripartum cardiomyopathy. As many patients improved dramatically on medical therapy. At the time, you can see the historical component, this ACE inhibitor, beta blocker, and spironolactone. You would add SGLT2 inhibitor today to that treatment plan, but nevertheless pretty good. And she continued to have atrial arrhythmias, had normal coronaries, and had an RB biopsy, which was unremarkable back in the day. This is probably 10 years ago. MRI had documented RV enlargement. Her ejection fraction was 37%. She was now class 2. There was some areas of fibrosis and delayed enhancement. This is also early stages of MRI characterization. I think we would retrospectively think different of this patient nowadays, but back in the day, we thought she'd be a good candidate for transplant. Here's an EKG with a pattern of pre-excitation and a lot of supraventricular ectopy. And so she actually did pretty well for 6 years. We followed her. We saw her every 6 months, as we usually would do, patients who were concerned about. And really, despite optimal medical therapy, she continued to decline and, in fact, got a resynchronization device with no benefit. Then she had repeated ablations because these atrial arrhythmias were associated with compensation, and eventually was transferred back to our hospital because she had acutely decompensated and now was requiring inotropes. And as you can see here, pretty severe LV dilatation, her EF down to 15% with moderate severe mitral regurgitation and a low cardiac output. So the patient was again, respond reasonably well to inotropic support, but it's a good time to point out, when do we think about right heart catheterization? It's really a class 2 indication, despite some of the negative publicity of the Swan-Ganz catheter. The response to initial therapy is inadequate. If you have uncertain about the volume status or you're unclear what are the filling pressures, then it's a clear indication. If you've got hypotension or multi-organ dysfunction, you got a problem. And if inotropic therapy is not enough, and you're considering mechanical support and heart transplantation, then right heart catheterization is a must. And in fact, you can see here that despite being on high levels of inotropic support, as you can see here, her index was only 1.3. This is very low with a mixed venous saturation of 36%, which begs the question, how is this patient able to function? And it's called the amazing human body and chronic adaptation to poor cardiac output. But nevertheless, at the time, we had an intra-aortic balloon pump, femoral implanted no less, intra-aortic balloon pump with marked improvement of hemodynamics. We use axillary intra-aortic balloon pump now to help the mobilization of patients, but this is just the way things were. And of course, as we did that, the patient did improve to the point that we proceeded with HeartMate 2 Divide as a bridge to transplant, because we felt at the time that the usual waiting time of months on femoral intra-aortic balloon pump was not feasible on 1A classification, which is what the patient would have been on. and the wait would have been months. And she did very well. Had this is an ideal LVAD patient. That's a HeartMate 2 device, so that's the old device. We no longer implant these devices. But she didn't have HLA sensitization, and fortunately had no bad-related complications of bleeding, stroke, pump thrombosis, which used to plague the HeartMate 2 device, and waited 4 years on that level of support. Very active, still taking care of her child, and I think even working to some degree while on VAD support, and eventually got transplanted and is now at least 4 years out support and doing well. And, it's easy to forget. Of course, I'm presenting you a good case, but I like PJ to comment. I mean, in this day and age, this isn't ideal. It's what we had before, but how would she done nowadays if she presented this year to our program?
It's fascinating, right? I mean, I think with those hemodynamics, we would not have put in a balloon pump. I did this last night with very similar hemodynamics. We would have put in an Impella 5.5, and she probably would have recovered a little more rapidly. Now, because of the way that the listing is today, that individual could have gotten a heart right off of the Impella 5.5, and in our program probably would have. But at the same time, if it's predominantly left ventricular failure, using a HeartMate 3, very much like this, would have also been a reasonable option depending on patient desires, depending on blood type and organ availability. Transplant still requires immunosuppression. It is a long recovery. You would need to stay within the range of your transplant center at least 3 months, if not a little longer. This patient may have even opted for a very similar course with a HeartMate 3 or transplant. I think both would have been options if this was just today.
It all comes down to availability of more choices to tailor for the patient, right? So we have temporary circulatory support, shorter waiting times with an aggressive program of organ harvesting. But there's also the question is how long does that heart going to last? And there are people in our community who will argue that, hey, mechanical circulatory support, durable mechanical circulatory support is not that bad because it buys you some quality of life time before you have to face transplantation. A lot of things that you have to discuss with patients, and you're right. We would have had slightly different technology we would have used, but the end result probably the same.
Might have been similar, yeah.
Might have been very similar. Before I jump on to that, and this is great because we can when we're at that part, I want to be as interactive as possible with the audience. So we have international patients. I'm trying to read this. How do they get rank? Is there an issue using U.S. organs to transplant international patients when there aren't enough organs? Well, that's a good question. I mean, historically, there used to be this sort of self-imposed cap that we didn't want to have, the majority of your patients being international patients. We, of course, as an institution that sees a lot of international patients because of the history of the Mayo Clinic and the Mayo Brothers, and taking care of adult congenital heart disease patients where they see little expertise elsewhere, we have been sort of kind of thrown into it. I would tell you that they are not listed any difference. They don't have any specific designation that they're going to get somewhat different organs. It is, contrary to popular beliefs, a small number of patients. And actually, our emphasis has been more in interacting. I, for example, have interacted more with South America just because of my background, and trying to lift other centers to be able to do transplant. Just because, that to add to it language barrier, social barriers, coming out here to frigid Minnesota, and then have to live here for a certain period of time post-transplant to be successful becomes a challenge. But obviously, you raise a red flag if all you were doing were international patients. But there hasn't been a big concern about using organs for international patients.
Right, but if they're here, we list them the same way. They're open to the same organs that anyone else is. And again, we're in a plethora of organs right now in the United States. We're I hate to say it for some of the wrong reasons, we do have an organ availability that is unique to the United States, largely due to the opioid epidemic. And anyway, if the organs are there, it seems right to use them to help someone if possible.
Correct. I think it comes down to philosophical decisions and making sure that, I mean, to me as a transplant provider, and I share with patients, is the main issue is that they understand the magnitude of the gift and make good use of that gift. Regard the patients.
Regarding patient
Have you
number one.
performed genetic testing in her now?
Great.
Perfect timing,
Yeah.
even just perfect. So let me just answer that question with my next slide. And actually, this is part of the reason first of all, this is a lovely patient that we just love taking care of. But she actually had a genetic cardiomyopathy. We didn't know it at the time. You keenly picked up on the fact that there were many features of her presentations that were of concern: urine age, arrhythmias with WPW. And in fact, when she had the pathology looked at, a fantastic pathologies of ours looked at that and said, this looks like a glycogen storage disease. And indeed, we did genetic testing and find out that she had a LAMP2X linked mutation, which is more common in women because they're the only ones who survive this mutation with the X link. And they get WPW and a dilated cardiomyopathy. The males fare much worse. And there's a couple of, I'm going to expand on your question. There's, of course, the genetic counseling because she has a child. And this is a mutation that we can screen for in the population. But there has been an explosion of our ability to detect genetic diseases earlier, as I alluded earlier in the talk. And these patients, we used to say, and I joke about this, we used to tell patients, you got a new diagnosis of heart failure, there's a 30% chance you will get better. There's a 30% chance you'll be the same, but do okay on medicines. And there's that 30% chance things will get worse and you'll need transplant. Well, guess what? The 30% chance that gets worse and needs transplant are largely fueled by genetic variants like this and others. And so nowadays it is standard for any patient who comes with an undefined cardiomyopathy. We can look at MRI characteristics and imaging, but for most of them, we will be doing genetic testing to try to discern. And in fact, we're detecting genetic abnormalities up to 50% of patients that we're seeing with more advanced heart failure. We are going to jump up to our modern era, and PJ, if you want to walk us to our next case, I think this is one that will be very interesting for the audience.
Excellent. Thanks a lot. We'll do one more here and open it all up for questions. So this is a more modern patient done in the last couple of years. This is a lovely 30-year-old Amish woman who presented in acute cardiogenic shock to our emergency room. As you could see, she was very small and cachectically thin. And she presented to our emergency room essentially in peri-arrest. She was emergently cannulated in the emergency room for VA ECMO. And you can see with rather small cannulas, given her size, she could only get a 15 French arterial cannula in. And that's because she was tiny. And she was also very clamped down in terms of her arteries. But we were able to save her life, and she woke up. So she has a diagnosis of congenital propionic acidemia. So she had been sick for a long time. She had a sister who died at the age of 12. And the issue with this disease is almost any protein consumption led to a malaise, wasting syndrome, and over time had led to essentially complete biventricular heart failure. And over her life, she'd gotten a little bit better and a little bit worse, but eventually this became end stage here at 30 years of age. She had an adorable child, loving family, and here she was in deep trouble. She had an echo that showed a very enlarged left ventricular chamber size and an ejection fraction of 12%, a pretty severely reduced right ventricular systolic function, severe MR that was functional, but most importantly, cachectically thin, absolutely unable at that point in time to tolerate any large heart operation, and probably would be for some time. This is her initial echocardiogram, so you can see some movement of her heart, but really global systolic dysfunction and very large heart on chest x-ray suggesting chronic disease. And at this point, she had been cannulated for VA ECMO, and you can see the venous cannula entering her field on the chest x-ray. Now, we needed somehow to bridge her over a long period of time, and femoral VA ECMO was not exactly the way I wanted to do it. So we had to think about a number of things. She had a chronically indwelling PICC line that you could see that was entering her left IJ. Unfortunately, due to multiple PICC lines throughout her life, she had stenosis of her upper extremity veins. So we used the PICC line to initiate nutrition support and a feeding tube, as she needed a very specific formula to put on any weight. And I started with the placement of Impella 5.5. And I can remember an argument with Dr. Clavel. He really pushed me to do this because I said, how am I going to fit this in this very small woman? And we've since published a couple of times showing that even with a small axillary artery in the young patients, you can generally fit the Impella 5.5 in because their arteries will stretch. So we fit that in to support her left ventricle, empty her left ventricle, and then think about our next step. So it's still on VA ECMO, but now with an Impella 5.5 and initiation of appropriate nutrition support. But again, VA ECMO over a period of what I was concerned was going to be months was not going to be possible. So we've developed a right ventricular support technique using a cannula in the pulmonary artery. So we initiated RV support through the contralateral femoral vein with a long 17 French cannula into the PA. So we had drainage from the right atrium using that large drainage cannula, injection into the main pulmonary artery, removal of the oxygenator to decrease her risk over a long time of thrombocytopenia and her extensive need for anticoagulation and stroke risk, and then left ventricular support with the Impella 5.5. So now she's essentially on biventricular acute mechanical support and continued aggressive nutritional support. And so this took about 6 weeks, and we were able to get her BMI from under 15 to 18. We were able to rehabilitate her in the hospital, multiple walks. We really had this woman walking around with bifemoral venous cannulation and then right axillary Impella cannulation. And we were able to expand on her medical illness, and we had genetic input, hepatology input, and eventual liver input, because we found that this storage disease existed in the liver. And I was informed by our genetic colleagues and hepatology colleagues that if she were to receive not only a heart for end-stage cardiac failure, but a liver as well, we could prevent the recurrence of her heart failure via this storage disease so that she could eat a nutritious diet at home with a heart liver. So at 2 months after the initial ECMO cannulation, we were able to proceed with sequential heart, then liver transplantation. So that was a really profound success. As you can see, we had a short cardiopulmonary bypass time, a moderate donor organ ischemic time. This came from moderately far away, followed by a liver transplant in this now 33-year-old lady. Oh, excuse me, the donor was 33, the recipient was 30. So you can see this is her explanted heart. Didn't look terrible, but again, remember this is the small donor, so it was large in her chest, but otherwise did not have the demonstration of ischemic heart disease. This was clearly a congenital cardiomyopathy. And then in her chest, you can see her new heart just banging away, extremely vibrant. And then we passed her 1 year just about 3 months ago. She's now on a sirolimus-based anti-rejection therapy. She had one episode of 1R rejection that was treated aggressively and has since recovered. And she's living independently in her community, consuming a normal diet, taking care of her child, bringing her back and forth to school, all in all living a relatively normal life with the exception of immunosuppression and regular follow-up.
Yeah, and PJ, this is, I remember that. Okay, thank you for reminding me about the challenges. And the reality is that when we do what we do, challenges are a normal thing every day, and how we get through them, I don't know. But this is, I think, the highlight here is multidisciplinary team, having the genetics, the hepatology team, working well with the hepatology team. We've done it. We didn't expand on this, but we do a lot of multi-organ transplants, more than many institutions, mainly because we are part of a transplant center and have that cohesive team approach with the liver and kidney team. And of course, the lung team is easy because it's us. Anyway, so those are the better ones, the heart lung. But in this case, people will wonder, extremely debilitated. I can attest to you that 10 years ago, without all this level of support, she would have died. she would have never gotten to transplant. So it's a good example of where we're at now, that we can support somebody like this and then mobilize them. And kudos to our nursing team and ICU team that are able to take care of these patients in an incredible way for us to be able to tell you this wonderful story of this young woman. I don't see any additional questions right now, so please, if you're not sure, go ahead, use the Q&A. We have about 10 minutes left of time here. We have another case, and I can kind of quickly go through it while we're waiting to see if there's any other questions, because I think this will give you the final impression of what we can do nowadays. And this is a 41-year-old non-ischemic cardiomyopathy, Becker's muscular dystrophy. If you're not familiar with these patients with Becker muscular dystrophy, their muscular component it's a limitation, but they usually do pretty well. They die of heart disease. They have the very high rate of bad cardiomyopathy, and in fact was admitted elsewhere with cardiogenic shock. We have not known this patient until that admission. And much like our patient, they ended up doing a Bipella device to provide support. So that, PJ, can you expand? That's an Impella and a Protect Duo. Yes.
In this particular case, it was pardon me. It was I think it was indeed an Impella 5.5 with a Protect Duo placed in the in the IJ. So it's not quite a Bipella. That would be an Impella 5.5 with an Impella RP Flex, but it was biventricular support with an RVAD system and a Centromag and the Impella 5.5, so biventricular mechanical support.
And this is not unusual to see hemolysis, smaller devices, small entry point, the high revolution. Sometimes you can see hemolysis. That's something we deal with every day. But that's basically biventricular support using percutaneous approach. But then, as is often time a problem, if you can't match them properly, you'll get pulmonary edema and hemorrhage because you got one pump running on another. And eventually this patient was transitioned to BA ECMO, which allows you to bypass that problem and then leave the Impella as a way to decompress the non-contractile left ventricle. So that's the configuration that eventually the patient landed on. That, of course, was here. Unfortunately, as a result of that, developed acute kidney injury and was on dialysis and had a fair amount of problems with the central VA ECMO washouts and wounds. And so that led to transition to discuss about transferring here because the transferring center wasn't ready to pursue cardiac transplantation in this scenario, particularly with the suggestion that this may be a multi-organ patient. So that's part of the reason patient came here, had a tracheostomy, which was kind of a bit of a disaster with the bleeding tracheostomy, one of these sort of challenging patients to assume care on, but we did. The patient wasn't necessarily adequately supported. You can see here the first echo we got, we were still seeing severe MR, severe right ventricular dysfunction, and the F was 15%. This patient now was awake and conversant, so there hadn't been any, thankfully, he hadn't had any neurological complications from the aftermath. But the left lung had a severe degree of injury, and he was not producing any urine on CVBHD. What do you do? Obviously it's a transplant consent, so we're going to talk about. But these are your options here. I mean, you either consider heart transplant alone, which is probably not going to be an option, heart and kidney, and see if you could rehabilitate that lung. I want to reemphasize again, this is massive hemorrhage into the lung with injury. So the timeline of recovery, if any, of that lung would be suspect and then fraught with potential for infection complications. And then obviously the consideration for triple organ transplant versus hospice on a 41-year-old relatively viable. Despite the diagnosis of Becker's, we have had tremendous experience with Becker transplantation in Becker on patients who have done very well for a long period of time. So we knew we could potentially help this patient. And of course, he was 2 months on BA ECMO trying to kind of sort this out. You can see here that eventually we, after much discussion, elected to pursue heart-lung transplant and had a kidney transplant as well. So this is a triple organ transplant. This is a chest x-ray after the transplantation. You can see here bilateral lungs transplant, but most importantly, the patient's renal function was excellent. That sometimes is a question mark where you're doing triple organs, where you have to get through heart, lung first, and then do a kidney transplantation. But this patient's kidney worked very well, and in fact was discharged after 21 days.
Right.
Following transplant, and in fact, was just about to hit a year. I think this is a little, it's probably in the 9-month mark now, and doing very well. And, highlighting that, as challenging as it may sound, multi-organ transplantation can offer opportunities in the younger population who have gone, clearly this is, and we've had some cases like this where there has been a lot of injury to other organs as a result of their heart failure. And this is kind of what we were talking about earlier. This is what you want to avoid with mechanical support. But sometimes, you don't get that chance. And then you have to decide, what do we do with this? I wouldn't say that this is an exceptional case.
Yeah.
And I think you can attest to that as well. So I don't want you to walk out of this webinar saying we can do this on everybody. But in selected cases, you can do this and you can be successful. It's kind of part of what fuels what we do here.
Yes.
So hopefully you got that that feeling. I think yes, we're on to the questions and answers. So we can sit here for a little bit and chat some more, and wait and see if there's any comments or question, any thoughts as we kind of look to this fascinating
I think
presentation.
All of these, we really wanted to highlight how you grow your program, take care of your patients by giving your patients the benefit of the doubt. The best advice Dr. Villavicencio ever gave me when I was in training was you want to look for the reasons why to support your patient, why to value your patient, why to transplant your patient, and not for all the reasons why you can't. So that's, I think, a really good way to sum up that beginning part. But then you do need all the tools in hand. And in this last case, really shows, for an ICU to be able to maintain a patient on VA ECMO with all those complications of a bleeding trach, renal failure, and not only support them but get them better physically is really the remarkable thing. And that is the kind of unity of care required for a patient that sick, and to just keep looking at them and say, we have a neurologically functioning human being who is responding to the therapy and getting stronger, to then take it on the program to give them a chance and to be open to the offers that come whenever they are. Because I know in the middle of the night, I often will be exhausted or whatever, and you get a good offer and you have to take it because that's your patient's opportunity. This is their one moment to say, this is their opportunity for a really good organ for a really sick patient, and to really have the passion and motivation, right, to say, let's do it together. And so I think that's the great thing about working in a center and working in this field in particular, is it is so multi-dimensional.
This is a good time to tell you that we take phone calls from the region and everywhere, 24/7. Obviously you can see here a few of these patients were transferred to our institution. The one particular patient you presented was told elsewhere that there was nothing else they can do, and she actually presented to the emergency room in a very opportune time. To go on ECMO cannulation in the emergency room is unheard of. But again, when you got a young patient with a potentially correctable condition, it's hard to look the other way and say there's nothing you can do. There's two different situations here. So this is, I think that I think gives you a highlight of what we do year in and year out. And we are certainly here for about another minute if you have any other questions. Otherwise, I cannot thank you enough for tuning in this afternoon. This was actually a lot of fun.
Yeah.
We should do it again. We actually got some time to talk with the surgeon that is not on the route to the ER or to the operating room ICU. Certainly appreciate you tuning in.
Thank you very much. Such a pleasure. Always great working with you, Alfredo. It's just a dream to come here.
Thank you very much.